throw somebody else under the bus.
All right, everyone, I think we're going to go ahead and get started. Hope everyone's had a nice break. So this next session is focused based on subtype of Castleman disease. So in here is the idiopathic multicentric Castleman disease subtype, but I believe there's another room down the hall that's unicentric Castleman disease and HHV8 positive multicentric Castleman disease. So if you fall into either of those categories, I definitely recommend going down to that specific session. It also means you won't have to hear from me for the next hour. So yes, UCD and HHV8 positive MCD are both down the hall. This room in here is idiopathic multicentric Castleman disease. Like I said, I'm going to be filling in for Fritz Van Ree. Another reminder about our Castleman Flex competition. Take pictures doing your flex, post them onto social media. We're gonna have a prize. I don't know what it's gonna be, but we're gonna have some sort of cool prize for the Castleman Flex winner. Great, so I'm gonna have to skip ahead in this. Here we go. All right, so I don't know how many of you all have know Dr. Van Ree. I know that some of you see Dr. Van Ree, and he's amazing. Like I said, he was supposed to be giving this session. Oh, and he's on the chat. So you can even ask questions to Dr. Van Ree and he can respond virtually. And I guess that means he's also watching us. So hello, Dr. Van Ree, which is great. I'm going to do my best Fritz Van Ree impersonation. I'm not going to speak with a Dutch accent, Fritz, but I will do my best to cover your slides. So just starting out with some basics about idiopathic multicentric Castleman disease. This is a rare and serious disease that affects individuals of all ages. So our youngest patient that I'm aware that's been diagnosed was less than 1 year old at time of diagnosis. Oldest patient into the 70s at time of diagnosis. The average age for diagnosis is in the 30s, but that doesn't mean that if you're not in your 30s that that's atypical. It's just average age of people is in their 30s, right? And so that's why the average age for Castleman disease is typically in the 30s. This citation says 50s. That disagrees with what we've seen through Accelerate. Our Accelerate registry, it's 35, 36 is the average. But I do agree with the statement below it, and that's that men and women are affected equally. It's a rare disease, as you guys all know. I'm sure when your doctors diagnosed your iMCD, that they may not have even seen it before. So that's one of the big challenges here. And then bottom right, we've got a very sobering statistic that actually has been changing over the years. This is a study that came back out in 2012 that 1/3 of Castleman's patients will die within 5 years of diagnosis. We've made a lot of progress over the last 11 years since that statistic, and the more recent study that we just performed suggests that that number is about half now, half of what it used to be. So it's around 17% of patients will die within 5 years of diagnosis, which I take as like a major victory that we've cut the mortality rate in half over the last 11 years, and we still got more work to do. Got the other half to take care of. But really, really happy that we've made the progress that we have. But I do realize seeing that statistic can be very startling and striking. I remember when I first saw the paper 11 years ago, it really struck me. But just know that we're moving in the right direction. So patients with Castleman's do tend to have worse outcomes than patients with unicentric Castleman disease. This is a study primarily done in China, and this is in the advent or the time before siltuximab was developed. We know that siltuximab is what's called a disease-modifying drug, which means that it improves your outcomes. It really treats the disease for a large portion of patients. And so the statistics from a group like this, primarily in China, again, that's now a 25 or 26% 5 years mortality rate is worse than we see here in the United States. But I think it's important for us to share data with you. You know, as I shared earlier, we're going to share with you everything we know about Castleman disease. Some of these statistics are hard to read, but I can promise you that where we are today in 2023 is further ahead than studies that were done in 2012, for example. That was before siltuximab was ever approved. We did do a study recently that's going to get published in the next few months. It's currently under review with a journal, sort of characterizing the burden of what a iMCD patients experience. And we looked in the Accelerate registry. So I'm hoping that everyone in this room has joined Accelerate. And we were really struck by just what all of us have gone through. There had never been a sort of wide-reaching study done like this that is based on the thousands of pages of medical records that each of you contributed to us. So as I shared earlier, you join our registry, we request the thousands of pages of records that each of you have in your medical charts, and then we have a single person go line by line through every one of those records and extract data into our registry. For some of you, it can take over a month, full-time, all day, every day, for a person to spend over a month going through your case. And we spend time, me then, going through that case with the data analyst. And so all that data that we have collected on all of you, we went through it. We were pretty shocked by the average patient spends over 30 days hospitalized in their first year after diagnosis with IMC. And of course, there's some patients, I think the most was 200 days hospitalized in the first year after diagnosis. And so we all know that Castleman's is bad, but obviously these are, over 30 days hospitalized is very difficult. It's a lot. We also found that 1/4 of iMCD patients receive dialysis. So to get dialysis, that means your kidneys are failing. They're not working appropriately. So you take dialysis to replace kidney function. Amazingly, 1/4 of patients receive dialysis. And then about 16% of patients are put on ventilators. So ventilators, as you know, are sort of like the last stages when your lungs are failing. No one wants to be on a ventilator. And again, a really large percentage of patients, so almost 17% of patients are on a ventilator in their first year after diagnosis.
Wow.
We all know that these things are difficult, and maybe I shouldn't be too surprised by them, but anyway, Accelerate sort of just revealed what we all know and what we've all experienced, but it is really clear that we iMCD patients do go through a lot. Let's see. This is just a table from the paper, and like I said, Fritz was coming up until yesterday afternoon, so these are all Fritz's slides. So I'm doing it on the fly. But let's see. I think the big takeaways here are that there are two subtypes, or at least two subtypes, of idiopathic multicenter Castleman disease. So I'm just going to maybe take a step back and remind all of you, to be diagnosed with idiopathic multicenter Castleman disease, that means you have to have multicenter Castleman disease, which means you have multiple and large lymph nodes. You have to meet the criteria for Castleman's, and you have to not have HHV8 infection or POEMS syndrome. And so that's what makes it idiopathic. Idiopathic is our fancy term for we don't know the cause. And so that means you have iMCD, and then within all those people of iMCD, some people have what we call Tafro syndrome, and that's where we have really low platelets, we gain lots and lots of fluid, our kidneys tend to fail, and we get big livers and spleens. And it's an acronym, Tafro. We tend to be the most severe cases. And then there's patients who don't have Tafro syndrome. Typically, they have high platelet counts, they have high gamma globulin levels, they have less fluid accumulation. Those patients we sometimes called NOS, meaning not otherwise specified. Some of those patients we sometimes called IPL. But basically, you either have really low platelets, really, really severe, or you have high platelets and you're not as severe, but still severe, or still serious. So in our registry, we found that over half of our patients have Tafro syndrome. So 61 out of the 102 iMCD patients. Disease. In Castleman's, we see kind of the opposite. The younger you are at diagnosis, the more likely you are to have really severe Castleman's. Again, that's like sort of the opposite of like all other diseases. And then I don't need to get in the right too much, but just to say that when you have Castleman's, I think it's important to follow a couple blood tests. And it's not that you need to feel like you need to be tracking every blood test possible, but I think it's good for you to be aware of a few. So one of them is your hemoglobin level. When you hear someone has low hemoglobin, hemoglobin, they get called anemic. Hemoglobin is sort of a marker that your Castleman's isn't being well controlled. Another one is albumin. Albumin is made by your liver, and again, low albumin levels or low hemoglobin is a bad sign. But a single low number isn't that big of a problem. You want to sort of see the trend. Is it like staying low? Another one is platelet count. Some people have really low platelets. Some people can have really high platelets. You want to keep an eye on what your platelet levels look like. And the other one is your creatinine, so how well your kidneys are working. And if you have a good idea for those four things, plus the fifth one would be C-reactive protein, which is a marker of inflammation. If you're looking at those five things and they're generally looking pretty good, then you can feel pretty good about how your disease is under control. And again, it's not to worry you that you need to be following all these, every day, but just it's good to, as a patient advocate, to be on the lookout for CRP, hemoglobin, albumin, platelets, and creatinine. Those would be the five that you want to keep an eye on. And this graph on the right is just sort of highlighting that patients with Castleman's have really low albumins and really low hemoglobins, which you just feel lousy when those two levels are low. Patients spend a lot of time hospitalized. So these red bars are the amount of time that each of us have spent hospitalized. You can see that some of us spend less time hospitalized, others spend more time hospitalized. So each row would be one patient. And you can see a lot of us actually spend a lot of time hospitalized before we're ever diagnosed. The diagnosis happens in the middle of that, but some of us can spend months hospitalized before we're ever even diagnosed with Castleman's. We talked about days hospitalized. Through this study, and again, using accelerated data, we found some things that we didn't really expect. Again, maybe it won't be surprising for you because it was your data that led to these findings, but not surprisingly, hematopoietic issues were the most frequent problems. That's blood issues. That's why we like to call Castleman's a hematologic illness. The second highest was respiratory, and the third was GI. We really weren't expecting GI problems to be such a big part of Castleman's, but it's like over 80%, over 80% of patients had some GI disturbances, so nausea, vomiting, abdominal pain, liver issues. That's not in any medical papers out there. Like no one's ever said, oh, Castleman's GI issues. That's just never been observed. It's not because it hasn't happened. It's just because like the data's never been put together in one place. And so this paper will get published soon, and all of your doctors will hopefully quickly become aware that like, yes, we should be concerned about GI issues in Castleman disease. It's not just that like my patient happens to be unusual. So I think that was probably one of the biggest surprises from this is just how much GI. About half of patients had neurological problems, which it's been previously reported, but I don't think we expect it to be that high. And then on the right side of the screen, you can see some of the procedures that are done. About half of patients have fluid taken out of their bellies. So that's called paracenteses, where you get, needle put in and fluid comes out. About half have red blood cell transfusions. I'm happy you're here as well. We mentioned the dialysis levels and ventilator. So then time spent in flare. So this is a bit more subjective. So in our registry, we determine whether someone's in flare or in remission. And most of you all will probably recognize that that's kind of a hard decision to make. Like flare means that your Castleman's is active and you're sick. Remissions means that it's not active and you're healthy. But as you know, it's kind of gray for many of us. I feel very fortunate right now. I'm in a complete remission, which means all of my blood tests are normal. It means that all my symptoms are gone. I feel great. But for many of us, we're sort of in the gray area. Like, am I in flare? Am I in remission? So anyway, that's just a caveat I want to mention. But based on what our data analyst called you all at various stages of your disease, whether we said you're in flare or you're in remission, you can see that a large portion of time people spend in what we call a flare state. So the plot on the left says that the average TAFRA patient spends 1/4 of their life after diagnosis in flare. 1/4. So a lot of time in flare. And even more surprisingly is that the NOS patients, which are the non-TAFROs, spend 50% of the time after diagnosis in a state of flare. And so though TAFRO tends to be more severe and more life-threatening in the moment, the non-TAFRO patients tend, tend to have more ongoing symptoms. So TAFRO is sort of more episodic. You're either like really sick, like you've seen pictures of me, or really healthy, like I am right now. The non-Tafro patients tend to not get as sick as Tafro, but they tend to also not to get as healthy as the Tafros can get into it. So it's sort of like a just sort of more in the middle on both sides. We also looked at the diseases that had been diagnosed in patients before you got your Castleman's diagnosis and those things diagnosed after. And we were hoping that we would find something that could sort of explain this whole thing. Like maybe all of us had our tonsils taken out like a year before we got Castleman's, or maybe we all, I don't know, ate a bad sandwich or something. That would be great, right? We wanted to find like a smoking gun like that. But we didn't find that there were any clear things that happened before our Castleman's diagnoses. If you look at the things that were diagnosed in us before Castleman's, they're the same things diagnosed in like everyone in America, right? So it's hypertension, obesity, asthma, GERD, depression, increased lipid levels, anxiety, vitamin D deficiency, ADHD, and diabetes. This is like exactly what America deals with. So that tells us there wasn't anything like that very clearly happened in us that like could explain, oh, well, that's why we all got Castleman. So obviously that was disappointing because we wanted to find something, that we all had that could really explain it. But what's notable is that after Castleman's diagnosis, all the things that are the leading diagnoses are really related to the disease. And so renal failure, anemia, you do hypertension, pneumonia, depression, hypothyroidism, angiopathy, sepsis, sleep apnea. So the things diagnosed after diagnosis are very different from the things diagnosed in patients before diagnosis. The only one that's shared actually in that list is hypertension and depression are both still diagnosed on both sides of the diagnosis. So I've talked a lot about Accelerate. And again, I hope that everyone in here is in Accelerate, and if you're not, I hope you will join the registry. But really, it's our amazing way to get a lot of data on this disease and learn more about the disease. I like to think about Castleman's as kind of being like a puzzle, and every one of us is like one small puzzle piece. And so if you look at us on our own, you can't figure it out. But if we put all of us together, then we can start to learn a lot. So we talked a little bit about the subtypes. This is just a little bit more on the various subtypes of iMCD. I think it's good to know what your subtype is. We don't recommend different treatments based on subtype. We think everyone should get IL-6 blockade first, and if you're really sick, get chemotherapy. But I think it's helpful to know what subtype you have because doctors can sort of start thinking about what to expect in your case. Like, are you going to be the really aggressively sick and then the much healthier type? Or are you going to be more like sort of always in between, like kind of sick, not totally healthy? So I think it's helpful to get a sense for that. It's important to also recognize this regional group. So there's some people who might be in the audience right now who they say, well, I don't know if I have UCD or MCD. I've got like some features that are kind of like MCD, some features that are kind of like UCD, and I sort of fall in between. For years, there wasn't a category for you, but more recently, we've realized there's actually a large number of you. There's about 30 out of the 100 and something that we were studying that have this sort of what we call regional Castlemans or oligocentric Castlemans. And so what we've learned about these regional cases, so you might have two regions of enlarged lymph nodes, is that your case, though technically multicentric because it's more than one, so it's multi, it typically behaves more like unicentric Castleman disease. But again, there's always exceptions to this. So just really important to recognize that you might be a little unusual, but because of the registry, we've learned that there's typically other unusual patients like you that we can hopefully learn from. We mentioned earlier this idea of regional or oligocentric. Again, they typically tend to be more like UCD and less like MCD. Also, the inflammatory response I mentioned earlier, that the non-TAFRAs, or what we call NOSs, sometimes tend to have less extreme inflammation. So you can see on the left C-reactive protein, which is a marker of inflammation. There's high levels in the TAFROs and some of these IPLs, but these NOS patients who don't have either of those subtypes, they tend to have much less inflammation. So again, that's why it's helpful to know what your subtype is. And if you don't know what your subtype is, and this is like, I'm doing this too quickly, come up to me during the break and we can talk through your case and I can say, I think you are this subtype, because I think it's helpful for you to know. Again, this sort of regional type of Castleman disease doesn't really fall into either category. And so now the way we think about the disease is subtyping Castleman's into there's unicentric, there's multicentric, and now in the middle there's this regional group. And then within multicentric, there's 3 causes of multicentric Castleman's. And then within iMCD, there's 3 subtypes of iMCD. So we've really been breaking the disease up a lot, but it's important because we find that depending on where you are within these boxes, there's a lot of different things you can expect than if you're in another box. So we came up with treatment guidelines a few years back, which have really been a game changer for doctors to treat patients in an evidence-based way. Something I'm really proud of. It was a major effort, but we've been able to help a lot of people as a result of it. So what are those guidelines? Well, here's an image of those guidelines, and what I think you should immediately take away is that we recommend different treatments for your iMCD depending on how severe you are. So if you are in the intensive care unit and all of your organs are shutting down, then we have a different sort of path. We call that the severe path. And if you're not in the ICU, you might still be very severe. You might still be in the hospital and very sick. We call it non-severe. We've been sort of rebranding that as mild/moderate because I think non-severe can make it seem like it's not an issue. It is an issue. It's just not in the severe category. So we have 2 different paths depending on which category you're in at that moment. But importantly, regardless of whether you're severe or not severe, what you'll notice is that the drug that's recommended with category 1 evidence, meaning it's the highest level evidence, is a drug called siltuximab. So siltuximab blocks interleukin-6, which I shared earlier is really important in Castleman disease. And there's been a large randomized controlled trial that's demonstrated that it's safe and effective. And now there have been multiple studies that have shown that it's safe and effective for a long time in a large portion of patients. Somewhere around 1/3 to 1/2 of patients will have a really great response to therapy, and somewhere around half of patients won't respond very well to therapy. But regardless of whether you're severe or non-severe, we recommend IL-6 blockade upfront with siltuximab. There's some people in this room that are on it, and their lives change. They return to normal. They look great. And it's just amazing. Unfortunately, the guidelines have to continue past siltuximab because some of us, it doesn't work completely. And so for those of us that it doesn't work, if we are severe and you're getting worse while you're on siltuximab, then that's where we recommend that you get aggressive chemotherapy. And that's because chemotherapy can work really well, but we want to hold it and just use it in patients who you absolutely have to use it. So in the most severe cases, we recommend really aggressive combination chemotherapy if the siltuximab is not doing the trick on its own. Whereas in the non-severe cases where you have sort of the luxury of time, you don't need to be, blasting someone with chemo. We want to make sure you give at least 3 to 4 doses of siltuximab, which is about 3 months or so of treatment, to see if it works. And if it's not working, then you want to start thinking about using other drugs. And so that would be rituximab would be next in line, immunomodulatory agents like thalidomide or sirolimus, which we have a clinical trial of here at Penn. Sirolimus is the drug that worked for me. I sort of failed to respond to everything for Castleman's. And then it was sirolimus that I started testing on myself, and that has really been a game changer for me. And we have a trial open for patients who fail to respond to siltuximab. You can then become eligible for our sirolimus trial. Before I go to anything else, I actually might pause here just for questions. I know this is like a really important slide, and I'm sure you guys are all thinking about your cases. Any questions before I go to the next slide? Cool. Well, feel free to write all these questions down so we can make sure that we get to them later. So why is siltuximab recommended first line? It's been studied in what's called a randomized controlled trial, where you randomly assign a patient to either get siltuximab or to get a placebo. I don't know if there's any patients in this room. No one I'm immediately recognizing. If anyone wants to volunteer if they were in the siltuximab trial, you don't have to if you don't want to. But yes, I don't think it doesn't look like we have any siltuximab trial patients in here, but trials where there's a placebo, those are really helpful in understanding how well the drug works or doesn't work. No one really wants to be in a trial where there's a placebo, but it does help you to understand, wow, the drug really works or doesn't. So this is the only trial that's ever been done in Castleman's where there was a placebo. And what we found was that there was this really substantial response in the patients who were on siltuximab versus the patients, obviously, who got placebo. And what we see now from our registry and also some follow-on from the siltuximab trial is that 34% of patients met the response criteria, but it turns out that somewhere around 50% that actually do benefit from the drug in total, whether they meet the criteria or not. So this is just saying that lymph nodes shrunk in patients. and highlighting that patients do well when they're on siltuximab. So this is one patient, Carl. I think he was either the first patient to enroll into the siltuximab trial, or he was one of the first patients. So he's had 300 doses since 2005. He's on the far left, and he's been doing great. He's still doing great. I guess 18 years later, and so we're thrilled for patients like that. The question that we're always thinking about is around, who are the patients where you can really expect that siltuximab is going to work. So we recommend siltuximab for everyone with iMCD, as we shared earlier, whether you're severe or non-severe. But we recognize that there's some people that you can sort of get a sense ahead of time whether they're really likely to respond or maybe a little bit less likely to respond. And it's actually the more severe patients that tend to be more likely to respond to siltuximab. It's not all very severe patients, but the more severe you are, the more likely you are that you will respond to siltuximab. And then a couple years ago, we established that there's a couple blood tests that we could run that can predict whether you're likely to respond or not. So if you have certain levels of 7 different things that are above certain thresholds, then you're likely to respond. And if you don't have those, you're much less likely to respond to siltuximab. I mentioned earlier, this is the research grade test, which means that it's not clinically available. You can't send it to a lab right now to have it run, but we're hopeful it'll become clinically grade, where you actually could have these sent out and you could actually get a sense for, are you likely to respond or not? We also, in the last year, discovered that one particular test, something called CXCL13, is a good early biomarker of response to siltuximab. So that means that if you test CXCL13 levels before you give someone siltuximab, then you measure CXCL13 again 1 week later. If it crashes down, then you're very, very likely to respond. And if it doesn't drop, you're very unlikely to respond to siltuximab. So it's a simple single test that would be run before and then a week later. We're also trying to make this become clinically available because it would be great for us. If your levels crash down, you basically say, hold the line, just wait to see if this is going to work. And if they don't crash down, then you might be more likely to say, okay, well, maybe I need to add something else into my regimen. Of course, it's important to remember that clinical trials have limitations. They're not necessarily reflective of how all of us do in the real world outside of clinical trials. And that's because there's really stringent criteria on who can enroll and who can't enroll. So that's why it is so important that you all join Accelerate. We talked earlier about Tafro. You might recognize that's me on the left, and I see Fritz very appropriately, blocked out our faces, and then Gary, that's you on the right. I hope you're okay with me sharing that, but you probably could recognize yourself. Again, the registry is just critical for this. I don't think too many things in particular. I think it's helpful to highlight the pediatric patients. So nearly 20% of iMCD patients are pediatric, and that's never been really described before. A lot of pediatric doctors will see a patient that looks like they have Castleman disease, and they'll say, man, this really looks like Castleman's, but the kid's only 5 years old, so it can't be Castleman's. It must be something else. And what we've learned is that no, you can have Castleman's at really young ages. And so we think there's been a lot of misdiagnoses over the years because doctors just sort of had in their mind, well, the average age of Castleman's is 35, so therefore you must be, well, the reason it's 35 is because that's sort of the average age of people, like we talked about earlier. And you can have kids, and you can have much older people get diagnosed. So that's important to point out. The number that are deceased, I think, is I think a positive that we should see, and that's that less than 10% of iMCD patients in our cohort are deceased at this time right now. I think that's great. That shows that there's this positive trend we talked about earlier. When we did a broader study outside of Accelerate, I mentioned it's about half of that previous 35%, so it's around 17% within 5 years. So we're moving in the right direction, and again, we're going to close that gap and get it to 0. A lot of treatments are used for Castleman's patients, even beyond siltuximab. So you can see here sort of all the different drugs that are used. About 85% of patients in our registry have received either siltuximab or tocilizumab, the 2 IL-6 blockers. And yeah, over half of them received siltuximab. You can also see steroids are really commonly given. And so in terms of response rates, over half of, we mentioned earlier, 34% of patients responded to siltuximab in the clinical trial, but in accelerated, it's about 55%. And so we think it's somewhere in that realm of 1/3 to 1/2 of patients. You can see that response rate is substantially lower for rituximab. And I will note anecdotally that not only is the proportion of responders lower with rituximab, but the intensity of response tends to be lower. And by that, I mean patients with rituximab may benefit some, but typically don't get all the way down to feeling as good as patients who benefit from siltuximab. And then certainly that's the case with steroids, where only 1 out of the 33 patients who got steroids alone actually benefited. Durability means sort of how long does the treatment work for, and the good news is that if you respond early, you tend to continue to respond. We do know of patients that have relapsed on siltuximab. I think there's even some patients in this room that have relapsed on siltuximab. There are. So it can happen, but typically if you respond well early, you will typically tend to respond well long-term, which is great because a lot of diseases, you might be doing well today, but tomorrow you don't know. Castleman's is a disease, it's consistent. If you're really sick up front, you're going to unfortunately be really sick with your relapses. And if you respond to a drug early, you typically tend to keep responding to it. It's not always the case, but that's better than a lot of other diseases. Let's see. And steroids are just not effective at all in Castleman's, though they're used often, but they really, if anyone in here is only being treated with steroids, please come talk to us and we can help find another doctor because they're really not going to be the treatment for you. And then in terms of length of time between adding other therapies, siltuximab does outperform other therapies in terms of the amount of time that patients spend on therapy before needing something else to be added on. Yes, and then sort of risk of relapse, we talked about before. There is a risk, but it's low. Great. So this is, I'm not going to spend a long time on this, but I did want to highlight IL-6 in particular. So when someone gets started on siltuximab, automatically your levels of IL-6 are going to go through the roof. They're just like, you're on siltuximab, and it has to do with the fact that the siltuximab binds to interleukin-6, and when you measure IL-6 levels in your blood, the test thinks there's a lot more IL-6 than there actually is. It's because it's measuring the drug too. So it's picking up IL-6, but it's also picking up siltuximab in the test. So the reason this is really, really important is that not that uncommonly, maybe once every couple of months, I get emailed from a doctor who says, I've got a patient, they're doing great on siltuximab, but their IL-6 levels are going through the roof. So I think they're relapsing. I think I want to take them off siltuximab. And I say, no, don't do that. The IL-6 levels are just increasing because they're on siltuximab. It's not that they're getting worse. It's not that there's anything wrong. Stop measuring IL-6 if someone is on siltuximab. So that's something that's really important takeaway, is that if you've ever received a dose of siltuximab, don't pay attention to any IL-6 levels for at least a couple years after your last dose. Yeah. Toci is like that. It's not as intense. So Toci will cause your IL-6 levels to go up, but not to the same like sky high level. So that's an important point. That's a key takeaway. If you're on either siltuximab or tocilizumab, don't measure your IL-6 levels and don't let your doctor worry about your IL-6 levels. Don't let them worry about it. So we've got a paper that's coming out, and what it basically says is everyone who gets siltuximab, their IL-6 levels go through the roof, and they're not getting sick. They're not relapsing. Everything else is, in fact, everything else is normalizing. They're actually getting better while their IL-6 levels are going up. So don't worry about the IL-6 levels. I had a doctor contact me a few years ago, said, I'm going to give my patient a bone marrow transplant, even though they're doing great, because the IL-6 levels are so high. And again, I was like, no, don't do that. The IL-6 levels go up when you're on siltuximab. So please do keep that in mind. Again, this is just another graph showing that people who get siltuximab, their IL-6 levels go up and they stay up. People who get placebo, their IL-6 levels stay the same. So don't pay attention to your IL-6 levels if you're on either siltuximab or tocilizumab. So the last several years have been really focused on trying to find new ways to treat iMCD, particularly for patients who don't respond to siltuximab. That's obviously the biggest unmet need, because if you do respond to siltuximab, that's great. It's effective for a long time. It's safe. It's tolerable. So it's really the people who don't respond to siltuximab that we're really focused on. And we've been able to discover a number of new approaches. So blocking interleukin-6, this is the discovery that I made several years ago, or I guess 9.5 years ago, which led me to start taking the drug sirolimus. We have a clinical trial open. Tracy Sikora, who's here, is our clinical trial lead for that and has done an amazing job with that. I don't know if any patients from the trial are here today, but it's a huge undertaking to launch a clinical trial of such a rare disease. And so it's just amazing all the work that Tracy's done. The trial's ongoing, so if anyone in here is ever on an IL-6 blocker and that IL-6 blocker is incapable or unable to control your Castleman disease, then you're eligible for the sirolimus trial. So if it's either due to the fact that it doesn't work or maybe there's some intolerable side effect of the IL-6 blocker, you would be eligible to join our trial. We cover all costs for you to travel to and from Philadelphia, cover all costs associated with the trial. And we even are very open to being flexible in terms of how often you would need to travel to Philadelphia or not, especially given no one wants to be traveling a bunch. Another drug that we uncovered a few years ago is drug ruxolitinib. I mentioned Kyla Mavis a bit earlier. We made a discovery in the lab, I guess it was about 3 years or so ago, and it made us think that this one part of the immune system, JAK-STAT, which is sort of a communication line your immune system uses to communicate with other immune cells, seemed to be turned into overdrive. And just about 2 weeks after that discovery, Kyla's doctor called me, and she'd been calling me pretty much every month for a year, being like, I don't know what to do for this young girl. She's not responding to anything. And this was sort of the last, like, any sort of Hail Mary effort. And it was, and I told her doctor, I said, well, just 2 weeks ago, we had this discovery, and I think that this part of the immune system might be important. You could try a JAK inhibitor. Her doctor tried the JAK inhibitor, and now Kyla is doing great, has been out of the hospital for over 2 years. Thanksgiving will be 3 years, right? Is that right? If I remember correctly? Something like that. So I think we need a round of applause for Kyla for being just a total pioneer. I don't think Kyla or her parents knew that she was the first patient to ever get a JAK inhibitor at the time. So I think that, pioneering, but yes, at that stage, it had never been given before to a patient. And again, it was like 2 weeks out of the lab. And we're always working, and we often are making discoveries, but it's sort of unheard of in medicine to make a discovery and then 2 weeks later have a patient be on it, and then to see her doing so well is like, it's like why we do everything we do. So I'm just so happy she's doing so great. Okay, so living with Castleman disease, this is sort of getting beyond what do we do to treat your disease, but also just sort of how do you manage having Castleman disease. And I love what Fritz put on the slide, and that's what to expect. And that's a very good outcome for most. And I think that's a good way to think about this. I think it's also important to know that when you have Castleman disease, the most severe moment of your disease, or the most sort of high risk moment for your illness, is within the 6 months before and after diagnosis. And so if you survive through those first 6 months before and after diagnosis, then you are going to be at a much higher likelihood of having a good long-term outcome than if not. So I suspect most of the people in this room are sort of in a different window than if you're currently in the midst of this early stage with this disease. And so again, I know that I keep talking about these statistics, and it's really just because I want you all to know that things are moving in the right direction. The scary statistics were from before siltuximab existed. There's reason to be hopeful, and I love what Fritz said, a very good outcome for most. And then he said, so what's the cost? And so the things that you need to think about in terms of, when you're thinking about a good outcome is, are there potential side effects of my drugs? Or is there stress and anxiety for my future that are going to come with this diagnosis? What's the effect on my family? Will I ever feel normal again? Can I get pregnant? Can my disease transform into cancer? And so I'll just take these sort of one by one and just share my comments. And again, I hope I do my best Fritz Van Ree impersonation. But in terms of side effects of treatment, it's really important to talk to your doctor about the side effects you're dealing with. There are some cases where the side effects are so intolerable that you should be thinking about a different drug. And because there's only one FDA approved drug, but there are a number of drugs that I've mentioned just today that have been used and can be used, that it's worth exploring. If they're totally intolerable, it's worth exploring, while at the same time remembering this is a really severe disease. And so if you've got a drug that's controlling your disease, you might have to deal with some of those side effects to make sure the disease stays under control. But have those conversations. In terms of stress and anxiety for the future, I completely understand and know the feeling that many of you all feel, whether you have the disease or you have a loved one with the disease. It is scary. It does create anxiety. And I think that this community that we have here is so important because you can talk to someone who's at a different stage than you. I shared with someone during the break earlier about how, for me, everything changed when I met a Castleman's patient named Daniel in Little Rock, Arkansas. I was in the ICU, all of my organs were shutting down. I felt horrible. And he walked in the room and he started telling me his story. He had spent months in the ICU. He had had big parts of his colon resected. He had had strokes that led to a number of neurological problems, but he looked great. And he was standing there and I could see him. And I just laid in the bed and was like, I want to be like Daniel one day. Like, I want to survive. I want to walk around. And now that I could see him, it became real for me. I was like, oh my gosh. And then, of course, Gary knows, fast forward a few years, and I was the Daniel, right? I walked into the room and I was healthy and looked good. And for you, you're like, oh my gosh, I can do this. And so, it all starts with Daniel, but we can continue to be that for the next person. So, if we're recently into our diagnosis, you can meet someone else who's a couple years ahead of you and you can see them doing well. They're back to work, they're back to school. And so please lean on this community so you can actually see it. It's not just the doctor saying you're going to be fine. It's actually seeing someone who's doing really well. In terms of family, again, family members can connect with one another for support. In terms of ever feeling normal again, I'm thankful that I feel the way I did before I ever got sick, and I think that should be the goal for all of us when we have Castleman's. In terms of pregnancy, there's a lot of unknowns with pregnancy, certainly on both sides, males and females, in terms of ability to get someone pregnant or to be pregnant. A lot of us have received a lot of chemotherapy, which can really impact your ability, of course, to have children. I'm very fortunate. I've got two amazing little kids. I've got a daughter who's turning 5 years old next week and a son who's almost 2. And when I was going through my journey, I didn't know if I would ever be able to have kids. I got a lot of chemotherapy, and thankfully I've been able to. And so, again, if that's something that you want to do in your life, talk to your doctor, talk to us. Maybe there's some ways that we can work with you and help to make this happen. And then in terms of cancer risk, the cancer risk appears to be a lot lower than we used to think it was. We used to think there was like a 3 to 4-fold increased risk of developing cancer. Now it appears that the reason we thought it was so high is that we believe that a lot of people that had cancer were being misdiagnosed as having cancer and Castleman's, when really they just had cancer all along. So they had lymphoma all along. And so that would artificially increase the numbers that you think have cancer from their Castleman's. So we actually think the risk of cancer is a lot lower than we used to think, which is great. And then these are some sort of ideas that Fritz put together about what can you do, find a good physician, learn about Castleman's, monitor your symptoms. We talked about those 5 blood tests. I should also emphasize symptoms too. Don't just worry about the blood tests. Pay attention to how you're feeling. Are you more tired than usual? Do you have the same appetite that you had? Tiredness is oftentimes a function of how much you're sleeping. So one thing we can all do as Castleman's patients is to make sure that we're taking care of ourselves, we're eating well, we're sleeping well, we're exercising, we're doing all the things that we should be doing. So that way, if we do feel tired, it's not, well, was it because I didn't sleep last night? Or is it because Castleman's is coming back? So do what you can. So that way, if Castleman's is coming back, then you can really be aware of it, because you're tracking those things. Take care of yourself, exercise, eat well, all that stuff. I'm going to skip through all this because I think we just sort of got through it. In terms of side effects, there are some side effects that are more common with certain treatments than others. Again, just pay attention to those sorts of things and talk to your doctors. I also like this image from Fritz. Don't be afraid of moving forward. The future is bright. And I think that it's even brighter today than it was 13 years ago. I was diagnosed on Friday, the 13th of August, 2010. And so this Friday, the 13th, which is like in 2 days or something like that, 3 days, I don't know even what day it is, will be 13 years. So, yeah, oh, thank you. Yeah, so Friday the 13th of August was obviously a horrible Friday the 13th for me. But that's when I first got sick, and now here we are 13 years later, and obviously have made a lot of progress. And yeah, the future is different than it was then, and we want to continue to get the future to be even more bright. So we are fully out of time. We got all the way through, and only 1 minute over. Thank you, Ira, for the time checks. We don't have any time really for questions, but if there's any burning 1 or 2 questions, we probably could get to them before we go to the break. And again, after the break, we've got an hour and a half just for questions. So any burning questions before we take the break? Sure. Sure. Yeah. Yeah. That's exactly how it was for me. So soluble IL-2 receptor is a really good marker of just how activated your immune system is. Like if your immune system is in overdrive, soluble IL-2 receptor will just go through the roof. And so it's actually, in my opinion, it's a great test to run if you're on siltuximab, because again, you don't want to pay attention to IL-6 levels anymore because they're not reliable. But measuring soluble IL-2 receptor is a great thing because it's going to tell you just how active your immune system is. And so, yes, having a sky-high soluble IL-2 receptor is very common in Castleman's, particularly TAFRO patients, and having like a mildly elevated IL-6 is also really common. So we oftentimes will have doctors say this patient looks like they have iMCD, but their IL-6 levels aren't that high. It's important to tell them you don't need to worry about IL-6 levels to make the diagnosis. You can be diagnosed with Castleman's with normal IL-6 levels or just slightly elevated IL-6. That's very common. And even in those patients where IL-6 levels aren't elevated, IL-6 blockade can be effective, which sounds like it is in your case too, right? So IL-6 was not elevated when she got sick. She got an IL-6 blocker. It made her better, even though IL-6 wasn't elevated in the first place. And that's because even if it's not elevated in your blood, there's many other parts of your body where it could be elevated. And also it may be that it doesn't have to be very high, but that it's just an important part of a circuit. Like if you knock out this one part of the circuit, the whole thing turns off. So anyway, these are really important things for you all to know and to make sure that sometimes you have to override your doctor. Sometimes you have to tell your doctor, actually, I went to the summit and I learned that we shouldn't pay attention to my IL-6 levels because I'm on siltuximab. And send them my way if they don't listen to you. But thank you guys all for the session and for a great question. And I'm excited for lunch. And then we've got our Q&A panel afterwards. Thank you guys so much.